Welcome to the Deep Dive. Today we're tackling really one of the most critical moments in IVF. It's that decision, choosing the one embryo that gets transferred.
Exactly. It feels like everything comes down to that single choice in the lab. Clinics give you statistics, success rates, but we want to dig into how that specific decision gets made right there under the microscope.
Right. So what's our mission for this deep dive then?
Well, we're going to break down the two main things the fertility team looks at. First, just the visual check that's called morphological grading, and second, digging deeper into the genetic quality with testing, known as PGT.
Okay, let's unpack this, starting with the visual part, the grading. What are embryologists actually seeing when they look at an embryo? Is it just a quick glance?
Oh no, it's way more systematic. Morphological grading is a detailed visual assessment. It's kind of like the first pass, judging the embryo by its appearance. Think structure, how the cells look, how fast it's growing. It's a key tool, but definitely not the whole story.
So what makes an embryo look good visually, especially in those first few days?
We look closely at two key points. First is day 3, the cleavage stage. Here, you're looking for a few things. Cell number, ideally you want about 6 to 8 cells.
Okay.
Then symmetry of the cells all roughly the same size. And really importantly, fragmentation. That's like little bits of cellular debris. You want as little as possible, ideally less than 10%.
Feels a bit like ticking boxes, but things get more complicated by day 5 or 6, right? When it becomes a blastocyst.
That's exactly right. By the blastocyst stage, we use a more sophisticated system called the Gardner scale. It's pretty standard globally. It uses a number, 1 through 6, and then 2 letters, A, B, or C.
The numbers and letters, that's what can be so confusing when you get an embryo report back. Can you break down what those letters mean? What cell structures are they grading?
Absolutely. So the number 1 to 6, that tells you how much the blastocyst has expanded or grown. 6 means it's fully hatched out of its shell.
Okay, expansion.
Then the first letter grades the inner cell mass, or ICM. This is crucial. It's the little group of cells tucked inside that's going to become the actual fetus, the baby.
Got it. ICM equals future baby. And the second letter?
That grades the tephectoderm, or TE. This is the outer layer of cells. Its job is super important too. It helps the embryo implant in the uterus and eventually forms the placenta.
So if someone gets that, that top grade of 4AA, what's that telling them?
A 4AA looks fantastic under the microscope. The 4 means it's nicely expanded, ready for implantation. The first A means the ICM, those future baby cells, look really tightly packed and numerous high quality. And the second A means the TE, the future placenta cells, look great too. Lots of cells, forming a nice even layer. Visually, it's sort of the ideal.
But here's something I found really interesting. These grades aren't fixed, are they? An embryo that looks maybe a bit meh on day 3 could actually look amazing by day 5?
Oh, completely. Embryos are incredibly dynamic. Day 3 is just a snapshot. You might have an embryo that looks a bit slow or fragmented then. But if it's got good genetic potential, it can kind of pull itself together and develop into a really high-grade blastocyst by day 5 or 6. We see those turnarounds. But the reverse is also true. A perfect-looking day 3 embryo might just stop developing a rest because of an underlying issue you just can't see visually.
Okay, so that perfect-looking 4AA, even that isn't a guarantee. If the visual check can miss something fundamental, it feels like we need to know what's going on inside the embryo.
That's the perfect transition. Morphology tells you about the structure, but it doesn't tell you about the engine, the genetics. And that's where pre-implantation genetic testing, or PGT, comes in.
PGT?
Yeah, PGT lets us screen embryos for genetic or chromosomal problems before we even consider transferring them. It gives us that much deeper look at viability.
Let's get into the different types. There's a bit of an alphabet soup with PGT. What's the most common one? PGTA. What's it checking for?
Right. PGTA stands for aneuploidy screening. Aneuploidy basically means having the wrong number of chromosomes, either too many or too few.
Like checking the instruction manual has the right number of pages.
Exactly like that. Humans need 46 chromosomes for normal development. Aneuploidy is actually the biggest reason why embryos fail to implant or why miscarriages happen. It can also lead to conditions like Down syndrome.
So the goal of PGTA is to find the uploid embryos.
Precisely. Euploid means it has the correct number, 46 chromosomes. That's the genetic green light, chromosomally speaking.
Okay, uploid is good. But what if a family knows they carry a specific genetic disease, like cystic fibrosis? Is there a test for that?
Yes, that's where PGTM comes in. The M stands for monogenic or single gene disorders. This is used when parents are known carriers of a specific inherited condition. PGTM lets the lab identify embryos that haven't inherited that particular faulty gene.
Makes sense. And there's one more, PGTSR.
Right, PGTSR is for structural rearrangements. This is a bit more complex. It's used when one parent has a known issue with the structure of their chromosomes, like a translocation, which increases the risk of having embryos with an unbalanced amount of genetic material.
It sounds incredibly precise. How do they actually get the cells to test without hurting the embryo? That seems delicate.
It really is. It's microsurgery, essentially.
Yeah.
The procedure is called a biopsy, and it's almost always done when the embryo is a blastocyst, so day 5 or 6.
Okay.
The embryologist very carefully removes a tiny sample of cells, usually just 5 to 10. But, and this is key, they only take them from the trophectoderm.
Ah, so only from the cells that would become the placenta, not the ones destined to be the baby.
Exactly. The inner cell mass, the future fetus, is left completely undisturbed.
Yeah.
After the biopsy, the embryo itself is frozen using a super-fast freezing method called vitrification.
And the cells go off for testing?
Yep, the biopsied cells are sent to a specialized genetics lab. Getting the results back usually takes about 7 to 14 days. The embryo stays safely frozen until the team knows which ones are genetically normal or euploid.
It sounds like a powerful tool. Who benefits most from doing PGT? Is it recommended for everyone?
Well, it's becoming more common, but it offers the clearest statistical advantage for certain groups, definitely women over 35, because the risk of chromosomally abnormal eggs, and therefore embryos, increases quite significantly with age.
Right, the age factor.
Also, it's strongly considered for people who've had recurrent miscarriages or multiple IVF cycles that haven't worked except by transferring seemingly good embryos. For them, PGT can really help identify the embryos with the genuine potential to lead to a healthy pregnancy, potentially reducing the time and heartache involved.
Okay, this leads us to probably the most fascinating part, the selection dilemma. Let's say you have that visually gorgeous 4A embryo, looks perfect, but then the PGT results arrive and boom, it's aneuploid. Wrong chromosome count. Meanwhile, you have another embryo, maybe graded a 3BC, looks okay, maybe a bit slower, not as pretty, but it comes back euploid. Genetically normal. What wins, looks or genetics?
Genetics wins, hands down. That high-grade aneuploid embryo, well, it might look like a perfectly wrapped gift box, but inside, it's essentially empty or has the wrong instructions. It just doesn't have what it takes to develop into a healthy baby.
Wow, that's a stark way to put it.
Whereas the 3BC euploid embryo, even if it doesn't look as perfect visually, it has the correct genetic blueprint. That makes it the far better candidate for transfer. Genetic health is just a much stronger predictor of success. So the recommendation is almost always going to be to transfer the euploid embryo, even if its morphology grade is lower.
So the embryologist and the patient really have to trust the genetic result over the visual grade. That must be tough for patients who might worry about transferring a fair or even poor quality embryo.
It absolutely is a mental shift, and it's so important for you, the listener, to understand this. Even an embryo graded with a C for its ICM or TE can still lead to a perfectly healthy baby if it's euploid.
Really? A C grade?
Yes. The lower grade might mean its chance of implantation is slightly lower than an A-grade euploid embryo, but the fact that it's genetically normal makes it viable. PGT helps us find those viable embryos that might otherwise be overlooked based purely on looks. It separates the ugly ducklings that can become swans from the embryos that simply can't.
Beyond just looking and genetic testing, are there newer technologies helping labs make these calls? Getting even more info?
Oh yes, the field is always evolving. A big one now is time-lapse imaging. Instead of taking the embryos out of the incubator once a day to look at them.
Which disrupts their environment, right?
Exactly. Time-lapse uses cameras inside the incubator to monitor the embryos continuously, 204/7, without disturbing them at all.
And what does that continuous monitoring tell you?
It gives so much more data. You can see exactly when cells divide, how long each stage takes, if divisions are even or symmetrical. Sometimes an embryo divides way too fast or too slow at a critical point, which can be a subtle sign of poor potential, even if it looks okay at the standard check-in times. Time-lapse catches those things.
Interesting. And I keep hearing about AI, artificial intelligence, making its way into the IVF lab, too.
Yeah, AI is definitely emerging. Algorithms are being trained on huge data sets of images and videos from past cycles, linking visual patterns to outcomes, whether an embryo implanted or not.
So the AI might spot things a human eye misses.
Potentially.
Yeah.
Yes. It can analyze textures, complex patterns, the timing from time-lapse, maybe more objectively than a human. The idea is it could provide an additional layer of data, maybe a viability score, to help embryologists refine their selections. It's still developing, but it's promising.
Okay, so you've used grading, maybe PGT, maybe time-lapse or AI. You finally pick the embryo. Are there any last little things the lab does right before transfer to give it the best possible shot?
Yes, there are a couple of supportive techniques. Sometimes for certain embryos, especially maybe frozen thawed ones from older patients, they might do assisted hatching.
Assisted hatch.
Yeah, they use a very fine laser to make a tiny opening in the embryo's outer shell, the zona pellucida. It just makes it a little easier for the embryo to break free and start implanting in the uterine lining.
Like giving it a little escape hatch.
Kinda, yeah. And sometimes they might use something called embryo glue. It's not actually glue, but it's a special culture medium used for the transfer that contains a substance called hyaluronan. It makes the medium a bit stickier, potentially helping the embryo adhere better to the uterine wall.
So little boosts right at the end.
Exactly, trying to optimize that very first interaction between the embryo and the uterus.
It really paints a picture of this incredible combination of, well, visual art, deep science with the genetics, and now cutting-edge tech like time-lapse and AI,
Yeah.
all focused on that one goal.
It truly is. And, all the science is amazing and getting better all the time. It does bring up some pretty profound ethical questions for us all to think about. Well, with PGT being so effective at identifying genetic issues, it pushes the conversation towards what else could we select for or against? It inevitably touches on the designer baby debate, even if current use is overwhelmingly focused on preventing serious medical conditions. Where do we draw the line? These are big questions science is forcing us to grapple with.
That's definitely something to mull over. A field that's constantly going to bring new possibilities and new dilemmas too.
Absolutely. And just before we finish, we really need to emphasize this conversation has been purely for educational purposes. It is definitely not medical advice. You should always, always talk to your own doctor or fertility specialist for personalized guidance.
Absolutely crucial. And if you're looking for more general information about the whole IVF process, you can find resources over at ivf4me.com. That's pronounced IVF for me.
Thanks for diving deep with us today.
We'll see you next time.